Good afternoon, students.
Good afternoon, sir.
So today we will go to a chapter on seizures and epilepsy. Can you hear me? Can you hear me?
Yes, sir.
Yes, you can hear me. Okay. So this is a important chapter, and it is important for your theory as well as for your day-to-day practice. So there is some difference between a seizure and what is an epilepsy. So that is the first thing that you have to understand. A person having a convulsion is basically having a seizure. And epilepsy is basically a chronic disease where the person is more prone to develop recurrent episodes of seizures. So that is the basic difference between these two. Seizures would require treatment of the primary cause, sometimes no treatment at all. Epilepsy has got a definite plan of treatment other than the treatment of the underlying cause. So what is seizure? Seizure is basically a transient occurrence of signs or symptoms due to an abnormal, excessive or synchronous neuronal activity in the brain. See, normally when you are awake, some of the neurons are in an excited state. At the same time, you should realize that your neurons are not in a hyper-excitable state so that you can control most of your voluntary activities. As regards the involuntary activities like movement of hands, convulsions, there is a regulation which inhibits excessive neuronal activity in the body. So if that particular inhibition is gone or there is an abnormal stimulation so that a large amount of neurons are synchronously activated at a time, either synchronously or abnormally, then you will get a motor response as a result of these neuronal stimulation. And what are these motor responses? These motor responses may be purely in the form of muscular movement, which is basically what you understand from a seizure, convulsions. It can also be abnormalities in the taste, abnormalities in the sense of smell, abnormalities in emotional activities, or it can be a combination of both. These abnormal activities can also be localized to one part of the brain and consequently a part of the body, or it can be generalized, affecting the whole brain and whatever structures activated by the brain. So you have to understand this distinction while considering a form of seizure. So that is the first point. Then secondly, paroxysmal events due to an abnormal or neuronal synchronous activity in the brain comprises a seizure. And depending upon the distribution, which I have already said, there can be different patterns of outcomes which a person can either see or elicit. Now, what is epilepsy? Epilepsy is a condition in which a person has a risk of recurrent seizures due to a chronic underlying process. This is a very simple definition of epilepsy. So, epilepsy will have a seizure, but seizures are not necessarily epilepsies. So, that is the distinction you have to make. A person with a single seizure or recurrent seizures due to a correctable or avoidable circumstance does not necessarily have epilepsy. For example, if a child develops a seizure with rise of temperature, the child will have febrile convulsions. These are seizures, but the child will not have an epilepsy. We will not consider it as an epilepsy. So that distinction you have to make. It can be a single, it can also be a multiple, but that does not mean that the person has got an epilepsy. For epilepsy, the person should have a chronic underlying process. It may be identifiable, it may be not identifiable, it may be due to a cause, it may be idiopathic, but that has to be there. Epilepsy basically refers to a clinical phenomena rather than to a single disease entity. It's more of a syndrome because there are many forms and causes of epilepsy. Clinically, for a thumb rule, epilepsy can be also defined as 2 or more unprovoked seizure. Here the provocation can be a rise of temperature also, like in febrile convulsion. So if we come to the prevalence of these two phenomena, seizure can be found in about 5 to 10% of the population. Will have at least one seizure during their lifetime. Since all seizures are not epilepsies, the incidence of epilepsy is much less. It's around 0.3 to 0.5% and a prevalence of about 5 to 30 per thousand. That is the same thing ultimately. So it is basically 0.5 to 0.3 incidence and 0.5 to 3% of prevalence. So this is basically what epilepsy is. It is much less than the prevalence or occurrence of seizures. Now, how do we classify? They can be either focal or generalized, or focal seizures originate within networks limited to one side of the brain. So whenever it is a focal seizure, it is only to one side of the brain. So in case of generalized seizure, the neuronal activity occurs in both the brains at the same time. Focal seizures are usually associated with some structural abnormality, whereas generalized seizures are usually associated with some either microscopic level, either a cellular or a biochemical, or it can also be a structural with widespread distribution, although there can be exceptions in both the situations. A very short classification of seizures, it can be of focal onset, it can be of generalized onset, and it can have unknown onset. So this is one way of classifying the seizures. Generalized can be again motor or non-motor. If it is motor, it can be either what you call it convulsions, tonic-clonic, or it can be in other forms of motor activities. Either there can be rigidity or simply coarse movement of the body, which we call it myoclonic, or it can be non-motor, when the person will have some amount of loss of orientation or cognitive powers, and motor parts will not be there. Now, in a broader classification, we divide it into two ways. One is a generalized seizures and the other is focal seizure. In focal seizure, you can have a tonic-clonic in any combination. It can be a absent seizure, either atypical, typical, or with some other special features. The third is a myoclonic absence, then only eye movement, which you can find. Then myoclonic can be either purely myoclonic, myoclonic atonic, or your myoclonic tonic. It can be clonic, it can be again tonic, and also atonic. So these names may sound very difficult, but if you just break them down into the components, they are not that difficult as it might appear. On the focal side, you will find basically what happens without impairment of consciousness or awareness. This is what is focal. It can be a focal motor, it can be a focal sensory. Number one. Number two, focal seizures may be associated with abnormalities or loss of consciousness or awareness. And the third broad group is an unknown type of epilepsies, which we call epileptic spasms. These patterns, the epileptic spasms, are not important for you. You find these in usually some preterm infants or with some birth abnormalities, which we normally don't find in either an older pediatric child or in an adult. So these are also not compatible with life. So we will not discuss those areas. So generalized, once the seizure occurs on both the sides together concurrently. Focal, if it occurs on one side. Clear? This focal can be associated with loss of consciousness or awareness, when we call them the complex, partial, or these can be without association of loss of consciousness or awareness, when we call them earlier as simple partial. So this is the basic difference between these two. And the third one, focal, can start as focal and transform into a generalized. So these are the three basic components of a focal seizure. And once they become a generalized seizure, it can take any of the forms which you are finding in the left column. So this is a broader classification of seizures. Now we divide it into the causes of focal seizures and generalized seizures. So I'm trying to make it as simple as possible without going into the details. Many of the focal seizures are without any cause, or secondly, which is more important or more common, focal seizures are usually associated with some structural lesions, which can be genetic, which can be due to infantile hemiplegia, it can be due to some embryonic problem, temporal sclerosis, cerebrovascular accident, tumors, trauma. Of these structural lesions, the ones that you will find very commonly are the last three. Cerebrovascular accidents, very common. You find seizures, focal seizures, which will turn into generalized. Tumors, any form of brain tumor. Sometimes they are diagnosed with a convulsion or a seizure. Trauma, including surgery, brain surgery. You find seizures. So these are very common, quite commonly associated, and where medications are justified. The eighth component of a focal structural, try to understand the component here. Just see the cursor, infective. That is also a part of your focal structural lesion. This is very common. Cerebral abscess, toxoplasmosis, cystosarcosis, tuberculosis, very common. Cystosarcosis and tuberculoma is very common. Subdural empyema, encephalitis, very common. HIV. And the last one, inflammatory, which can be due to any form of vasculitis, it can be due to some autoimmunopathies or sarcoidosis. Well, with this we close down the focal seizure causes. The causes of focal seizures are closed here. So now we go to the causes of generalized seizures. What are they? Number one, please mark out the first one if you don't mind. Yeah. Generalized or focal seizures once they are generalizing into a generalized seizure. So that is the most important cause. Then second one is basically genetic. Third is cerebral birth injury, then hydrocephalus, cerebral anoxia, certain drugs, alcohol, especially withdrawals, toxins, organophosphorus, heavy metals, metabolic, hypocalcemia, hypoglycemia, they produce seizures. Infective, you find in encephalitis with meningitis. Then multiple sclerosis and SLE with inflammatory, and some of the diffuse degenerative diseases like Creutzfeldt-Jakob disease or Alzheimer's. So causes of GTCS, generalized tonic-clonic seizures, it can be a part of the focal seizures which was described in the previous slide, or it can be due to some of the other causes, or it can be idiopathic where we don't know the cause. What is the underlying pathophysiology of a seizure? For normal brain function to continue, there has to be a balance between the excitation and the inhibition, which is going on continuously. During your sleep, during your general anesthesia, or during a person becoming comatose, the inhibitions are much higher than the excitations. So the person goes into a form of non-functioning of the body, including thought processes and other issues. When you are angry or you are excited or you are emotional, you do certain things which you would normally have not done, even in the society. So there is some amount of excitation, but you are still controllable. You would definitely not try to drive your car into the lane separator, or you would not try to harm somebody in that extent. But still this is an excitation, and these are voluntary efforts. But if the balance gets lost in the involuntary activities, the balance between excitation and inhibition, that is the prime point by which an epilepsy or a seizure starts. The inhibition is basically transmitted by the GABA and acts on the ion channels to enhance chloride inflow and reduce chances of the axon potential formation. This is the inhibition. And the excitation is basically by the glutamate and aspartate, which follows sodium and calcium influx. So many of the seizures has been documented to develop from an imbalance between these two combinations. So the intracellular recordings during seizures demonstrate a paroxysmal depolarization shift. Well, let us not go into that. And in 5.0, epileptic cortex shows repetitive discharges. If you do a active radio imaging by finding out radioisotope ions, then you will find that the areas where the excitabilities are there in a person having the seizure will show a high discharge. So from these, it has been postulated that there is a imbalance or dominance of the excitation over inhibition of the neurotransmitters in certain areas of the brain, which leads to overactivity of the particular motor responses in the body, which is involuntary. It is not voluntary. Now, the underlying pathology of focal epilepsy. Seizures may be related to a localized disturbance in the cortex, becoming manifest in the first instance as a focal seizure. Secondly, any disturbance of cortical architecture or function, that is a structural problem. Thirdly, if focal seizures remain localized, the symptoms experienced depend upon which area of the cortical area is affected. If it is in the temporal region, it might be affecting the speech or emotions. Frontal area, higher functions. Occipital, it might be related to visual loss. Motor cortex, hemiplasia. Sensory cortex, there might be sensory loss. When both hemispheres gets involved, the seizure is said to become generalized. So these pictures will show you the diagram A on the left, the origin of a focal seizure, the red star on the left occipital lobe. From there, the focus has come in and stimulated the mid part of the brain. And that at that point of time, the first part is the focal seizure. And once it has come to the central part and activated the entire brain, it is a generalized component. That is a focal seizure with secondary generalization. In the second picture, it starts instantaneously as a generalized pattern without a focal onset. So this is a totally primary generalized seizure. Now, what are the generalized epilepsies? Generalized epilepsies are generalized at the onset. The abdominal activity probably originating in central mechanisms controlling cortical activation and the spreading rapidly. And it constitutes about 30% of all epilepsies. And now seizure activity is usually apparent on the EEG as spikes and wave discharges. The other generalized seizures may involve merely brief loss of awareness. It depends upon what type of an epilepsy it is. It may be associated with loss of consciousness or may not. Now, the clinical features of an epilepsy. We first start with a generalized tonic-clonic seizure because that is a classical seizure. That is what you want to mean by a seizure, and that is the most serious type of a seizure which may produce lots of complications. So patients may experience more than one type of seizure attack, and it is important to document each attack type and the patient's age of onset along with its frequency, duration and typical features. So one should try to find out whether there is any trigger which might have triggered this activity. Lack of sleep, visual activities, straining on a TV screen, taking alcohol and getting a withdrawal. So any of these triggers, or not taking a drug properly. So these are the triggers. Identify whether there has been a focal onset and then it has gone into a generalized part. And also seizures which starts in the late adulthood, so mid-30s, is almost invariably a focal seizure with secondary generalization. Now in the generalized tonic-clonic seizure, A focal onset will start with a positive neurological signs and symptoms corresponding to the area from which it has arisen. So this is easy. Occipital will give you visual changes, temporal will give you a false recognition like deja vu. Sensory strip involvement would give you sensory alterations like burning, tingling, and motor strip or the motor cortex will give you jerky movements. If it starts with that and proceeds to become a generalized, we know that the origin of the focus is in one of these areas. Now, for coming to the focal seizures, if they are in the temporal lobes, if it has started in the temporal lobes, there might be impaired awareness. The patient stops and stares blankly, often blinking repetitively, making smacking movements of their lips, or displaying other automatisms, such as picking at their clothes. After a few minutes, consciousness returns, but the patient may be dazed or not fully oriented and feel drowsy for up to about an hour. The age of onset, preceding or a longer duration, and associated post-ictal, that is post-seizure symptoms, usually make these easy to differentiate from the childhood absence seizures. So there is a pattern called the childhood absence seizures, we will come to later. So the focal seizures can be differentiated from these patterns. That means there will be some amount of residual abnormalities lasting for some time. Now, anterior parts of the frontal lobe may produce bizarre behavior patterns. And to differentiate from psychogenic attacks, we may take the help of either continuous or video EEG recordings. Now, this is the most important type to be described, the tonic-clonic seizure. In this type of seizure, there will be an initial aura, which may be present, may not be present. It may be in the sense of a smell or a short realization, which may last for a very few seconds, during which period the person may not be able to protect himself or herself. Patient then becomes rigid. The entire body will become very spastic or rigid and will lose consciousness together. So as a result of that, they fall down like a log and might get injuries in the body, including facial and head injuries. Because of the contraction of the respiratory muscles, there will be cessation of respiration, although the respiratory center has not failed, and the breathing will stop. Consequent central cyanosis may occur. After a little while, maximum of 30 seconds to 2 minutes, the cortical neuronal discharges will reduce, and instead of the contractions, it will now turn into jerky movements, which is the clonic phase. The first one was the tonic phase, now is the clonic phase. After that, the clonic phase will also go away and the muscles will totally relax, leading to a flaccid state. Along with that, there is loss of consciousness, so there is a flaccid comatose state lasting for several minutes, and once the person recovers from that, there will be confusion, disorientation, and the person will have a retrograde amnesia. He or she will not realize what has happened to him, except for the injuries that they will find in their bodies. Urinary incontinence and tongue biting are quite common during the tonic-clonic phases. Subsequently, the patient usually feels unwell, very weak, very sleepy, with headache and myalgia because all the muscles have contracted for a long time, they become exhausted. There might be atypical patterns with delirium, headache, myalgia, and they may lead to the diagnosis rather than the description of the classical seizure. This is the second variety of generalized seizure, is the absence seizure. Absence seizure is very common in childhood. It's got a very good outcome and they recover with drugs almost completely. Always it is in childhood, they will develop in childhood, and these attacks would never be confused with a focal seizure. Because in focal seizure, some of the associated features are much longer. Here it is very fast. The occurrence of the frequency of absence seizures are very many, 20 to 30 per day. And what happens actually, the child while sitting in the classroom or at home suddenly appears to be inattentive for a few seconds. During that phase of inattentiveness, whatever the teacher has been telling or the mother has been telling will not go into her. She will not understand, the child will not understand what has been told. And this would be thought of by the teacher or by the mother or the father as daydreaming, as if the child is wandering away, thinking of other things. And he or she will not be able to explain because they don't know what has happened. Once they recover, they will think that I was totally aware why I am being scolded. This keeps on happening multiple times a day. They will not lose the consciousness. As a result, they will fare very poorly in their activities, academics or otherwise. So this is one of the commonest ways how the child is brought to the doctor by the father or the parent with a complaint from the teacher. The child doing very well till last year or last 6 months, now suddenly is not attentive at all in class, cannot answer my questions. Even if I ask something, she is not able to answer. So this is the way how they present. Because they don't have any motor activity. Remember that. Myoclonic seizure, these are very brief, jerky movements and more predominant in the upper limbs, more marked in the morning on waking up, provoked by fatigue, alcohol or sleep deprivation. Atonic, the person suddenly becomes totally flaccid and may lead to falls. If the person suddenly loses the tone in the body, the person will fall. May be associated with loss of consciousness, may not be associated, right? And may be associated with other epilepsy syndromes. It may not be an isolated pattern, a tonic part. There might be tonic seizures also. There is another variety, only tonic, with generalized increase in the tone and loss of awareness. It is also a part of epilepsy syndromes. In clonic seizure, it's only isolated clonic now, the last one. It is similar to the tonic-clonic, but the tonic phase is not there. So it is a generalized clonic seizure, but the tonic part is not there, the other components remaining same. But these are not so common. The first two are very common. The first one, that is the GTCS, generalized tonic-clonic seizure, occurring in all age groups, and the absence seizure typically in young children. The third group of seizures, which we had described earlier, if you come to this slide, generalized seizures, focal seizures and unknown seizures. Now we are coming to the third group of seizures. Seizures of uncertain, generalized or focal in nature. They may be generalized, they may be focal, but they are of unknown origin. They are not of much importance to you because they will occur only in very young neonates, preterm, etc. So we will not go into the details of these types of epilepsies. There are some trigger factors for epilepsy, which has been, I just described. Sleep deprivation, a person missing the doses of the anti-epileptic drugs, alcohol, especially withdrawal of alcohol, then abuse of drugs, exhaustion, physical or mental. If there is a flickering light, like in computer and TV screens, intercurrent infections, metabolic disturbances, and sometimes very rarely a loud noise, music, reading, etc. may produce this pattern of as triggers. Clear? How do we approach these patients? A person has been brought to you, to your chamber or to your hospital by an attendant, by the parent or by himself or herself, and saying that has had a seizure, could be any of the forms. What are you going to do now? A 12-lead EEG is taken for all patients which are loss of consciousness, if there has been a transient loss of consciousness, there are basically two groups of diseases that might produce a transient loss of consciousness. One is epilepsy or seizures, and the other one is syncope, cardiac origin of loss of consciousness, transient. So these are the two basic things you have to differentiate. Well, so an EEG is always required in any person coming with a transient loss of consciousness. If there is abnormality, it can be an epilepsy. If there is no abnormality, it can still be epilepsy. That is a very important thing. If you suspect that it's a seizure, you do a neuroimaging, either a CT scan or more importantly an MRI. So this is one thing you have to do. And if it is focal, then the chances of detecting is higher than in a generalized. The recurrence rate after the first seizure is about 40%. And most recurrences occur within the first 2 months. So the best way is to find out whether they recur or not, depending upon the job of the individual. Seizures are less likely if an identified trigger can be avoided, and the other investigations for any infection, ingestion of toxic materials, metabolic abnormalities has to be done. EEG performed immediately after a seizure will be more helpful than performed a little later. Those were the investigations for a single seizure. Now, what are the investigations required for an epilepsy? That is, 2 or more unprovoked seizure, or you already know that this is an epilepsy. Same investigations as you do in seizure will be required in epilepsy. EEG may help to establish the type of epilepsy and guide therapy. Investigations should be done again if the epilepsy is intractable to treatment, and interictal EEG, that means between the episodes. If you do an EEG, it may be abnormal in about 50% of the recurrences, cannot be used to exclude EEG. If it is normal, you cannot exclude that there is no epilepsy. There are other means, ambulatory video EEG, and then you take the help of the neuroimaging for structural lesions. So the most important thing to diagnose seizure and epilepsy is a history. A very good history is important. Followed by that, if you find a patient, immediately do an EEG. If it was a focal origin, some focal abnormalities in the EEG may be detectable. Done later may not be so easy to detect. If you do an EEG in between, it may be abnormal, good, your diagnosis is confirmed almost. If it is normal, does not exclude an EEG. Then the next thing that you do is, you do an ambulatory or a video EEG, or with provocation by sleep deprivation and other things, like doing a Holter for cardiology. And you also do the neuroimagings like a CT or MRI to find out any structural lesions. All of these remaining normal, the person may still have an epilepsy. That is a very important point you have to know. And for an experienced clinician, the chances of missing epilepsy by the history is very rare. They are able to diagnose. So what are the investigations? Different patterns of EEGs to be taken for the site of the epilepsy, where it has started. Cause of the epilepsy, you can do MRI, CT, metabolic, you do the renal function, liver function, blood glucose, calcium, magnesium. For inflammatory disorders or infective disorders, do the total blood count, ESR, C-reactive protein for inflammation, chest X-ray for tuberculosis, serology for HIV, syphilis, for collagen vascular diseases, and the CSF abnormalities to be looked for central nervous system infection or inflammation. Whether it is an epilepsy or not, try to get it out. If everything fails, including your history, do an ambulatory EEG to find out whether during the focus of the disease there is some EEG abnormality, or a video telemetry. That means the ECG machine is fixed to the person and the recordings are transmitted to a center. So this is the last resort. Most of the time we don't do these things. It is a history, a standard EEG, a MRI or a CT scan is done if you want to exclude a structural lesion or metabolic or inflammatory responses, if those are obvious. When will you do a CT scan or an MRI? In young children, it is not required unless there is a definite provocation. Seizures having a focal feature, EEG showing a focal feature, or the seizure is uncontrolled with drugs. You do a EEG, CT or MRI to find out whether there are gross structural lesions or not, where the treatment would be more drastic. How do we manage patients with seizures? There are different steps. What do you do immediately once you get a patient with seizure? Most of the time, it is not the doctor that will find the patient in the immediate care, unless under the hospital settings. The doctor or the healthcare worker will not get a patient with epilepsy. It is the attendant, the family member, or on the roadside, some fellow person who will find a person having a seizure. Then there has to be some lifestyle avoidances rather than advice. The third one is the anti-epileptic drugs. And once you have started the epileptic drugs, they have to be monitored, taken adequately, effectively, and side effects. Nothing responds, you go to surgery. If the person is doing well for 2 years or more, no seizures are happening with the anti-epileptic drugs, you gradually withdraw the drug depending upon the underlying etiology, and at one point of time you can stop the drug. And certain situations are there, like during contraception, what type of contraceptions you are going to use, pregnancy and reproduction, any things to be done in the elderly. And there is another important thing which is called the status epilepticus. I will not go much into the details of these issues right now. I will describe only the first one, that is the immediate care. What is the immediate care that you will be doing? In the immediate care, what you will do? A person has fallen down with an epileptic cry because of the spasm of the vocal cords and contraction of the respiratory muscles. The air inside the lungs will come out through a partially closed glottis that will produce a sound that is called the epileptic cry. And the person falls down like a log, and after a few seconds will start convulsing very rapidly for about 30 seconds to 2 minutes, and then fall back unconscious, breathing deeply. During this time, the person may have cyanosis and froth may come out from the mouth. This froth or the tongue or any food that was inside the body, inside the mouth, or the artificial dentures in an elderly person might be swallowed by the person. The person might have injured the head externally or bitten the tongue internally. So these are the possibilities that you get. May stop the breathing and asphyxiate and die, or the person may be deeply cyanosed. So what you're going to do or what you're not going to do, as a person, you're going to advise. Turn the person to the one side. Prevent the tongue from getting back. Do not insert anything inside the mouth, because whatever has happened has already happened. The tongue bite has already occurred. If you insert a spoon inside the mouth, which is commonly done, it is going to produce more injury. So these are things you are not going to do. Don't make the person smell ammonia or dirty socks of somebody. This is done by people. Never do that. Hold the person on the left side or on the right side. Restrain him as gently as possible so that he does not injure himself anymore. The person will go into breathing, and the airway, ABC, has to be cleared at that point of time. You can do not much. If the waiting person finds that the person is not regaining the consciousness within those first few minutes, immediate medical help has to be sought. Otherwise, the person will recover on his or her own. After that, the doctor's role comes in. For this, we will go to the next class. what would be the lifestyle avoidance, what anti-epileptic drugs, how you're going to monitor them, is there any surgical role, whether you are going to give the drug lifelong or you are going to stop it after some time, and certain special issues. We'll meet on next Friday. Thank you.